Yeah, so thank you for the introduction, Renee, and very good to see everyone. Lots of new faces for me, lots of familiar faces, but I have the honor today to share with you some of my work about how do we make guidelines that matter, which is not such an easy task if we're talking about rare diseases. But before we start, I would like to see who's here and what do guidelines mean to you. So if you open the QR code on your phone, you can answer some questions. Yeah. So first question is, do you currently use ERNICA guidelines? So many people that use our guidelines. Some are not familiar. Maybe you can go to the next question. So this is an open question. You can answer with any words that come to your mind. But what do you think? Why do we make our guidelines? There it is. So maybe we can take a look together. So the bigger words are the things that are mentioned more often. So people say quality of care, consistency, improve care. I think that is all correct. And then there's people saying things about evidence, evidence-based, best quality, evidence-based practice. So these are all concepts that are related to guidelines, I think. So let's go to the next question. How much experience do you have with guidelines? So I know maybe a bit how much context I should give to certain concepts that we will discuss in this hour. Okay, so I think we have a mixed audience, people with more and less experience, which I think is good. So hopefully we can also learn from each other. And then the last question is more like a quote I would like you to have your agreement or disagreement on. So this is something that we hear often. You can't make good guidelines without good evidence. And how would you see that in the current moment? So we are more or less 50-50, but there is still a lot of people that would say agree, which I can understand. So let's go back to the presentation and see where we start today. So this is a figure that we use more often within ERNICA. This is called our quality cycle, and it has all the elements that contribute to quality of care. So as you see here, there is the guidelines. The guidelines have an important place in the quality cycle. So if we want to have high quality care, we first need to define what actually is quality. What does it mean to us? So that's what we do in the guidelines. Then after that, we of course need implementation. And then we also try to measure the quality of care and then use those measurements to evaluate our clinical practice. So what is actually happening in clinical practice? And can that, again, tell us something about how we describe the quality of care? So why do we make guidelines? I think from early on, medicine used to rely on tradition, authority, and local customs. It was heavily influenced by clinicians' opinions. And as a result, two doctors treating the exact same condition could give completely different treatments. So I did a little bit of digging on this, and the first example I found was an article from 1938 describing large differences across regions in the practice of adenotonsillectomy. And actually the conclusion of this first article was that there must have been a difference in incidence of this disease across regions. And it was not until much later in the 1970s, 1980s that they discovered that it's much more likely that this difference was because of different practices and physician habits instead of differences in disease incidence. So this is where evidence-based medicine started. So then we had in 1972, the first article of the Cochrane collaboration. I think most of you will know Cochrane as an institute. And this is where they started to bring the concept of evidence-based medicine into the world. So their vision was that randomized trials should guide clinician decisions, and that clinicians need reliable summaries of research. So this was the start of the Cochrane collaboration. So today we all think that it's very normal that RCTs are the highest level of evidence and that we need to use them for clinical decisions. But back then this was revolutionary ideas. So in those years there has been so much progress in this field. And then at some point there was also groups at McMaster University in Canada, which later on became the GREAT collaboration. And they created an intellectual foundation for guidelines and creating the idea of including the best available evidence, integrated with clinical expertise, and also consider patient values and preferences in this. So over the years, the GREAT group has published over 50 papers explaining to us how they think we should make guidelines. And this goes from very conceptual things to very complex papers on the analysis of certain literatures. Two important things that came from the GREAT group is there were a lot of different ways to determine the quality of evidence. So people said we have evidence levels 1 to 4. Some people said we have high to low. And in the GREAT concept, there was a shift from only looking at study quality to determine the quality of evidence to determining the quality of evidence based on outcome measures. So an outcome measure can be, for example, mortality, length of hospital stay, concepts like that. So in the GREAT, you pick relevant outcome measures and determine the quality of evidence for each outcome measure separately, which was a big transition from all the other concepts that there are. Then a second thing that is important in all those 50 papers is the separation of two important concepts that we use for guidelines. So the first one is the certainty of evidence, and the second one is the strength of recommendation. So for many years, people have used these concepts interrelated or as one, but in the GREAT group, they have said no, they should be separate things, which also results in that you can have softer or more conditional recommendations, even if you have very high quality evidence, but also vice versa. So it also gives us the opportunity to make stronger recommendations if we have less evidence. So as a summary, why do we make good guidelines? We want to describe a good quality of care and set a standard, summarize reliable evidence. We want to support clinical decision-making and reduce unwarranted variation in care. And this last point is something that in ERNICA we think is very important, because what we ultimately want is that it doesn't matter where the patient is born in Europe, and that they can profit from the same level of predictable and equitable care. So a great guideline, the basis, how does it work? So you start with making a question, a PICO question. I think we all know PICO, but it stands for Patient Intervention Comparison Outcome. It helps us to specify what we want to know. So after that, as I just said, we're not longer looking at study design, but we're looking at quality per outcome. So we need to select outcomes. A panel discusses what outcomes are actually important if we want to answer this question. Then we rate the importance, and then we measure the quality of evidence across the studies. So if we have 5 studies that say something about this outcome, we take them all together and measure the quality of evidence over all these studies together. So then there's the great evidence system, which says that if you have a randomized trial, then the initial quality is high, and if you have an observational study, the initial quality is low. Then based on these considerations, so the risk of bias, inconsistency, indirectness, imprecision, publication bias, you can decide to reduce the quality of evidence if there's something wrong with the study or the methods, but also if you have a very large effect or a dose-response relation or opposing bias and confounders, then you can also decide that for an observational study you want to increase the certainty of evidence. So after working this out for all your PICOs, you make some conclusions, and then you take that to the table with the panel. And the panel always considers all these elements, so the quality of evidence, the balance of benefits and harms, the values and preferences, feasibility, equity, acceptability, resource use, and all these things together make up for a recommendation. Then in the recommendations we can say either a strong recommendation, so we recommend, or a softer recommendation like we suggest. So to make this easier to understand, I have put up an easy example. This is purely exemplary. I will not stand for the actual conclusions of this slide, but just to see where do we start. So if we make a guideline about appendicitis, you can say what are the undesirable effects of primary appendectomy versus primary antibiotic treatment. And you say we want to look at the critical outcomes, the overall treatment effectiveness, and the length of stay. So I did an actual search on this, and I found a meta-analysis of multiple RCTs that says that the overall treatment effectiveness for the antibiotic treatments is significantly lower than for the surgery, and the length of stay is significantly longer. So we translate this into great conclusions, and we say it's likely that the surgery is more effective to resolve appendicitis, and it's very likely that the length of hospital stay is reduced if patients have primary surgery. So in this slide I have two conclusions from the same set of studies with two different grade levels. Is there someone who likes to take a guess as to why the first one is moderate? So it's downrated one level from the original high, and the other one not. Exactly. Yeah, so the first one has a high level of heterogeneity, making the conclusions less certain and for us to downgrade the evidence. So where does it leave us? We go to the panel and we start with these two conclusions. So we say it's likely that surgery is more effective, and it's likely that the hospital stay is reduced for patients after primary surgery. So the panel considers all these elements that are part of the grade framework, and then reaches a conclusion. So this is an example from appendicitis, which is not a rare disease. In a rare disease, we do have some challenges. Amongst that is the scarce evidence, there's outcome heterogeneity, and there is questions that do not fit the box of the PICO framework. So first to dig in a little bit deeper about scarce evidence. So Cochrane posed the idea that RCTs should be the golden standard for critical decision making, and methodological frameworks work with certainty of evidence. So if you don't have high quality evidence, you will always have lower certainty. So instead of saying that something is likely, you say maybe something, there is indications for something, or that something may be happening. And as you can imagine, if you already have an issue in the beginning of this whole process, all the other steps could be complicated. So just to visualize this, I did a search on appendicitis and inguinal hernias, and these are the total numbers of pediatric papers that I found. But then in ERNICA we work with rare diseases like esophagus atresia and omphalocele. Again, anyone who wants to take a wild guess as to how many total hits we found for EA or omphalocele? 400? Anyone more or less than 400 for esophageal atresia? Okay, yeah, it's much more. So it's almost 8,000 or 7,800. For omphalocele, less, but also not too bad. But then, ideally for the guideline, we want to use RCTs. So then the numbers look very different. So if you see, you have, if you want to answer a question about appendicitis and the difference between surgery or antibiotic use, there's 83 RCTs on children alone. So the likelihood of RCTs covering the outcome measures that you are looking for is higher. If we look at omphalocele, there's only 18 RCTs on the whole topic. So it's not even on the topic that we might have selected for the guideline. So this is how our process looks. We have search results. Then we want to look for comparative studies because we have comparative questions. But then we also want to look for the outcomes that we are interested in. So then you may end up with this or even with this. So how does that look in an example? So in the omphalocele guideline, we did a question on vaginal delivery or cesarean section. And we found one observational study, and it said no significant differences in mortality, and there were some differences in morbidity, amongst which a longer length of hospital stay. If you look at these conclusions, at how they are phrased with the grade very low, what do you think is the main difference compared to the ones that we saw for appendicitis? So I think, from my perspective, the main difference here is the wording that we use. So instead of saying something is likely, we say we have cautious indications. So we are very careful. So you can imagine, if you take this to a panel and compare starting a discussion from this versus starting a discussion from this, you have a very different point of starting your discussion. And usually this, you cannot lean so much on the evidence. So you have a very different way of discussing, and you have a high risk of falling completely back onto expert opinion only. If we look at one of the other challenges, is that in the rare diseases, often the outcomes are not so defined yet. So we have a lot of outcome heterogeneity. And what we want in the guidelines is to pool the conclusions from all types of studies. But if you have differences in outcomes, then it's from the few studies that you have, it also becomes complicated to pool the results. So, for example, I think we all know that there is still differences in definition of giant omphalocele. What we saw, for example, in the guideline on necrotizing enterocolitis is that we wanted as an outcome the neurodevelopmental outcomes for these children. But then we saw that there were 5, 6, 7 different scales that people used to measure this. So it's impossible for us to pool these outcomes into one stronger result. And then the last issue that we often see in rare diseases is that we have questions that do not fit the PICO box. So if you look at the PICO framework, then you need a question like, in patients with giant omphalocele, should stage reduction or non-surgical treatment with delayed closure be used to close the abdominal wall? Then you have a very contained, specific question. But often what we see in rare diseases is that panels come up with questions that are much more explorative in nature. So they want to know important considerations. They want to know how to recognize best practices. We cannot fit that into the PICO framework, and then this has effect on how we analyze the evidence that we find. And analyzing the certainty of evidence on an outcome level is hardly possible if you don't have a PICO question to start with. So this impedes all the other steps of the grade methodology. So what can we do? So within ERNICA over the last years we have made many guidelines and projects also with different methodologies. So the first issue or the example that I would like to speak to you about is what we did in the total colonic ganglionosis. So in this situation there were clinical questions that were relevant to the panel that were more explorative in nature. So think about what are best practices in surgical treatment, or what are important considerations during follow-up. And there was some evidence, but very little, because it's a very small subgroup of an already rare disease. So what did we do? Instead of choosing the formal guideline path, we chose to develop clinical consensus statements. And this is a process where we use a Delphi study to systematically collect expert opinion. but use statements that are informed by the best available evidence. So how does this look? You first decide on a scope, and then in this methodology, panel members are allowed to select broad topics. So we don't need such a strong specification as we do with PICO, but we can use a broader topic. Then we still do a systematic search and selection, and we've tried to find the best available evidence to answer those questions. Then we draft a list of statements. Those statements are initially based on the evidence, but if for some issues the evidence cannot be found, the statements may be completed based on expert opinion. And then we do a Delphi study as a sort of way to validate the statements that were drafted. So because the statements are usually based on very low quality of evidence, and so we also are not so sure about it, we use the opinion and the experience of experts in a systematic way to validate which of these statements can be seen as agreed upon and which not. So we do questionnaires, and then we exchange between the questionnaires with panel discussions, and then after each panel discussion a new questionnaire follows. You do this for a maximum of 3 rounds or until you reach the consensus criteria. So then we have another example, which was for the on-fellowship guideline. And this was a guideline where we were able to draw questions that are specified into a PICO format, but we already knew beforehand that the evidence base was very little. We did know that in our registry, the Pediatric Surgical Audit, that we also collect data on fellowship patients. So this is where the idea came in. If we don't have enough published evidence, can we figure out a way to supplement the publications with insights from our own patients that are in the registry? So this is where we designed a system that is called REGARD, Real-World Evidence for Guidelines Addressing Rare Diseases. And this is to be seen as a supplement to the regular guideline. So this is a figure that explains a simplified process of the grade guidelines. So we start with prioritization, PICO generation, then we do a systematic search, then we do a literature analysis, and if necessary or if desirable, you can supplement the literature with REGARD, so with insights from the EPSA. Then we have a panel discussion where we follow the evidence to decision framework. This is a framework that really gives us a structure in the discussion and leads to transparency in the arguments that are used to make recommendations. So by using this system, you can sort of take out the black box effect of a panel discussion, because what used to happen, I think it still happens a lot, but especially back in the days, is that all respected people in a certain field are gathering around the table, they have a discussion, and then they write something down. But then there's a big, if you read this, a big black box effect, because you often cannot follow the arguments why they decided on certain recommendations. So this is where the framework really helps us. So it helps us to systematically consider the same things for each question. And then we end with recommendations in the system. So very simplified how REGARD works is that we first present outcomes about the incidences of selected outcomes in patients in the registry. So for example, if we look at the comparison between vaginal delivery and primary cesarean section, then we select a few critical outcomes, and then we reflect on how often did those outcomes occur in patients that had the first option and patients that had the second option. And then because the numbers in our registry are still quite low, so in the on-fellowship registry there's about 250 patients, but because you make such strong specifications to the questions that you analyze, for some comparisons like 10 or 20 patients were left. So we couldn't make valuable or meaningful, I should say, statistical calculations. So that's why we asked our experts to become our statistical analysis. So we presented them with this overview of how often did outcomes occur. And then we asked them, so to your opinion, do you see any effects in the comparison between the first and the second thing? So you can say no effect, small harm, large harm, small benefit or large benefit. And so it's like a 5-point Likert scale. And all these things together about if experts say we believe there is an effect or not, we summarize it and we put it as a supplement to the summary of findings. So the summary of findings is usually where you summarize all the evidence that you found from the literature and also accompany it with tables that tell you something about the quality of that evidence. But in this case, we had sort of two sources in that summary of findings. So we had the published evidence and the supplement from the EPSA data. If you are interested in the results, the guideline was published last week. If you scan the code, you can go to the guideline. What the nice thing about using the new option regard was that we had about half of the questions in this guideline we had no evidence for. But by using data from the EPSA, we could reduce the questions where we had to rely on expert opinion only. So we could have a few questions where we didn't have published evidence, but we still could base the recommendation on the best available data. Because this is an audience that is specifically interested in rare diseases, we also have examples where even with the adjustments that I just told about on the grade method, you will not get there. Which is the case with a project that we did on anorectal malformations and accompanied vaginal agenesis. And for this project, we had the case that there is no guidance on the surgical management of this condition. The panel wants to answer a clinical question related to the best timing for surgery. There was hardly any evidence available, and there is very limited time and budget. So we thought we need to figure out a way to work efficiently, reduce the reliance on expert opinion only, but still work in a structured and systematic way. So it's not a coincidence. Pernilla Sandstrom is here with me in the room, and she was chairing this project. I think, do you want to share about the methods that we used? What we did here is we said we have an extraordinary situation where we have very little evidence. But we want to work systematically, and we want to reduce the bias that can be gained from using only expert opinion. So what we did is we used this system to triangulate knowledge from different sources. So first we have the published evidence. So in my opinion, if you're making a guideline, do a systematic search. Even if you already know there is very little, getting out the best available evidence is always a good thing to do. So the second arm of the triangle is the expert evidence. So what is expert evidence? This is a relatively new term that has come to the field of rare diseases. And this means that you systematically collect observations and experiences of people that are considered experts. So what did we do here? We invited a panel of experts to present on their own cases, so patients that they actually saw. And we asked all people to present these cases in a similar format. And then we had a discussion about these cases, and then we extended the conclusions that we could have about best practices in these cases to an international survey. Together we joined all the knowledge that we gained from that as something we call expert evidence. And then there's also, of course, expert opinion. So based on experiences, historical insights, cultural and ethical aspects. We used in here the nominal group technique to combine these three sources of knowledge. And what is important for that is that the nominal group technique is specific to decrease group thinking and authority bias. So authority bias could occur if there is a few very knowledgeable people in the room and they speak, and then the other says, okay, yes, I agree. What do we do with the nominal group technique is that we use silent generation of ideas based on the knowledge triangulation. So we presented all the experts with a summary of the evidence, a summary of the expert evidence, and we instructed them based on your expert opinion and these two bodies of evidence, think about what you think are good ideas for this patient population for 15 minutes. So everybody thinks about it in silence. Then we have a discussion where we record the ideas, and there is a rule that everyone can say one thing that they think is important, one by one. So everyone speaks one by one, and you can present your idea, and we can continue this until time runs out or until there's no more new ideas. So then we have a discussion where each idea that's on the list is discussed, and people that introduce that idea can explain the rationale behind it. And then we can also see if there's maybe some things that after explanation are overlapping or similar, and then we can group it to a shorter list. Then we ask the people, out of all these ideas you just mentioned, rank your top 5. So pick 5 that are most important, rank them from 1 to 5, and then we end with the voting. And what's important if you use formal consensus methodologies like this or like the Delphi technique is that you always decide in advance what is your consensus criterion. So how many votes do I need to be called something consensus, and in what case do I consider something to be out. So this is a process that we did.
So I just want to say that it was a little bit explorative.
Yeah.
But, so we identified a lot of strengths, but also limitations, of course.
Yeah, yeah. So and then I thought it might be nice, as there may be people in the audience who are interested in participating in the future. As you said, there are things that were exploratory, and there are things that could be better. What were your overall experiences? What worked and what could be better?
I would say with this methodology, we started, I think you went into a very important thing, Renee, and that is the group, that is the expert group, the super expert group actually. In this field or this methodology, there should be not more than 20, because more people, there is no room for discussion. And then we come to how to select these people, because that is so important on the papers. Which names are there? And there should not only be authorities. We have so many colleagues working, not being a name on papers before. So I think we have something. I know that ERNs have, questionnaires, and we have legacy around it. Maybe we should use that more and develop that part. That is a main consideration that we need to develop, I think. And I tell this since Wilhelmine couldn't attend this meeting. Your colleague Fenna was there. And another thing that what is very important is that if you are authority, you are very used to expressing your theories, your experiences, and it's very easy that one or two persons become shadowing the whole discussion. Okay, so what to do? We need to build trust in the groups. So if we discuss such a sensitive topic like should we replace vagina or not if there is no vagina at the time of PSARP? that is very sensitive. We also have urologists, colorectal, sexologists. We need to have trust in the group before we can start the deep discussions. Because after, I would say, 4 hours, it suddenly came up that people did a technique that were not even mentioned in literature. And long-term outcomes, there are no long-term outcomes, whether if you dissect or not the cloaca, I mean, if you leave the ureterogenital sinus, that was suddenly a specific discussion. Can we leave the sinus, or should it be divided? So that is a topic in its own. So, but to discuss that trust, and how do we build trust?
And did you think that the structure of this meeting, so how if we look at the different steps of this technique, did you think that it helped to make sure that everyone had equal participation?
If we go through the steps, first generating the ideas, that was brilliant. You know, it was in the room, it was quiet, and everyone wrote and thinking by themselves. And then to have your own slot to express your thought, that's brilliant. And then we had discussion. And then that is the third one. Very important to have a leader, you know, to distribute the time between people who want to speak. And that is very important to have a professional methodologist, in my opinion. Then we came to the step between discussion and ranking ideas. Here is a very sensitive step, because since English is not our main native language, it can be complicated, because we need to formulate the ideas so that people can say if that is an important topic or not. And we struggled a little bit with that, to find the right English words. And then going to the next step, we could see a difference. The 5 top rankings were not always equal to the time we discussed the topic. So there were topics being discussed for half an hour, but they were not on top 5. And maybe that was because of language. Maybe it was because of 1 or 2 persons thought that was important and not a group. We don't know.
Yeah.
And then I think it's very good to have to summarize in a voting.
Yeah. So I think this is a nice example of how you can still work in a systematic way, even if you don't have much evidence, and also how you can be creative with maybe even creating the expert evidence like we did. So the asking the expert clinicians to make sort of case reports of their own patients and summarizing the thoughts from that. But I want to, as a last, go back to what we did with the on-fallacy guideline. And I want to invite Carmen. We had a discussion, and when we first introduced the published evidence, and then introduced the conclusions that we could draw from the EPSA. So how did you experience that?
Well, I think it was a good complement and a necessary complement because we struggled with the gastroschisis guideline with the lack of evidence, and we feared that for on-fallacy it was going to be even worse. So we were discussing for a long time whether we should do a guideline or a consensus, and then probably you came up with the brilliant idea to try to combine, okay, what is the consensus? It's an opinion of experts. How do the experts do? How do they report into EPSA? What can we learn from there? That goes also together in line with how we're going to measure the implementation of the guidelines. So I thought it was, quite a very good extra help for some of the recommendations. They were based only on the EPSA data registration. But I think the best, what makes everything goes together so nicely when it comes to rare diseases and to avoid some people taking too much time on the discussion or too much space is the structure observation form that you make us fill in when we are coming down to this is the conclusions we can draw from the evidence or for the EPSA. how everybody interpreted, everybody have time to reflect and write own comments, and then you pull all that together, and it's the basis of a structured discussion. So then everybody already got the possibility to express what they think, and then you can capture, if you are a little bit shy in a bigger group, you can capture in these forms and can be brought into discussion. So I think this structured observation form is almost the most crucial part of all these guidelines with rare diseases and little evidence, and trying to make it.
So I think that I think that overall the conclusion of all the methods is that the structure of is important. Mm-hmm. So what I said before, that if you just put experts on a table and you have an open discussion, that there's a big black box, and that with structuring the discussion you can take out that element.
And it's crucial. I mean, we need experts, but we need methodologies like you, because otherwise it's like you say, some discussions can go on forever, and you can go from one thing to another, forgetting the target or where you're aiming to. So people like you are crucial for us to do this in a proper way.
Oh, thank you. So to close off, from this example, I talked about with Pernilla. We wrote a method paper on that, and we drafted some lessons learned. And then actually we thought there are so many things here that are relevant for whatever method you do. So just to give it as a takeaway is that your clinical questions are the basis for any project that you do. So proper specification of the question, whether it's PICO format or it's another format, is a crucial first step. Then if you consider working with expert evidence, draft a strict case format. So if people are presenting about their cases, or if you use the EPSA, make sure that you have a strict format as to what people should report, what they should talk about, what outcomes. And one thing that we didn't do in the expert evidence for the vaginal aplasia project is to ask people to submit their presentations up front, so we could check if they would comply with the format. And this is something that we will definitely do next time. But then there are, in the last box, I think a few elements. Where's my pointer? Not here anymore, but in the bottom row, things that are about consensus building. So we are in a room with a group of expert people, and there may be younger experts, older experts, experts from centers that publish a lot, experts from centers that publish less, but also have a lot of knowledge. So what we think is important is to create a safe discussion space and make sure that everyone has the opportunity to speak out. And there is different things that we can use to support that. So it's using the forms, it's using a one-by-one speaking format, but also what we often do in the guidelines is that I send out a questionnaire before, and then people can put in any thoughts, and then I'm the only one that can see it. So during the discussion, if I sense that someone is reluctant to speak, I can say, I have one comment in the questionnaire that says this and this and this. Is there anyone who likes to speak about that? So that is how we ensure that all perspectives are seen. And then the last one, appointing an impartial individual with sufficient anatomical medical knowledge to guide the whole thing. So in this case it was me. I think it can also be someone else. But the important thing is that you have an impartial individual to guide the discussion. So what I hear often, and René just told, I'm not a surgeon, so I really don't care what recommendation you come up with, as long as we follow the structure of the methodology. So that's why I can easily moderate in discussions that for others may be more sensitive or even emotional. But you can also have someone else fulfilling that role, I think. So to close off the session, I want to go back to where we started and ask you one last question. To see if maybe some of you have changed their opinion about the quotes that I gave you. So you can't make good guidelines without good evidence. And I remember from the beginning that we were 50-50. So I would be curious to see if people have changed their opinions. Then I think my job is done here, because I think we had a little bit of a shift in opinions about this topic. Thank you for your... Then inclusion of patient opinions is one of the key points for it to be valid. However, there is no strict one way to do that. So you can use different ways. One way that we all know is that we can give patients a role as panel members. So if we talk about the panel, then it's multidisciplinary experts and some patients. Another option is is what we did, for example, with the gastroschisis guideline, is to ask clinicians to send out a questionnaire to their own patients. And that is something that we can do if we don't have a formal patient representative that also has the knowledge and the time to sit on a panel like that. So I think that for whatever methodology you choose to use for a project, there's always possibilities to involve patients, and I think that it's very important to see what is the most effective way for the situation that you have. So if you have, for example, in the esophageal atresia, we have organized patients groups. We have people that have participated in project before, and those are people that I would dare to give a role on the panel if we can assure that I can give them extra explanation when they need it. I can give them a podium to speak if the discussion is too much towards other things. But in some cases, just a patient that has just their own experience and is not involved with the role of being a representative for the bigger group, then it might not be such a good fit to put someone on the panel. So then you might need to find other ways to collect their opinions and experiences. Other questions? No? Then...
Thank you, Willemijn.